Thank you for coming, everybody. I'd like to bring Trevor Wilkins from ScaleHealth into the center stage here, if you will, and bring Paul Reiser from MedHealth onto the center to do a little brief introduction. We're glad to have you here today.
Thank you so much, Stacy. Hello, my name is Trevor Wilkins, and I lead growth at ScaleHealth. Thank you all so much for attending today. We're so excited to have you and really looking forward to tackling this very important discussion today. For a little bit of insight, ScaleHealth, we are a healthcare innovation hub based here in Los Angeles, California, but we have a global reach. Really, we were built with the idea that innovators in the healthcare space and stakeholders in the space continuously missed each other. We're fortunate to have some great founders, some great institutions, investors here in the great city of Los Angeles that just kept missing each other. We built ScaleHealth about 2 years ago, started building it, and from there we're able to start making these connections. Have had some great success, but I think one of the biggest successes that we've had is connecting with great similar groups around the nation and around the world, like Tech Town in Detroit. They are our first partner outside of Southern California, and when we started discussing burnout amongst physicians, this came around very quickly, and they've been amazing partners in this and outside of everything, and we're excited to have a great turnout for you today. And with that, I'll pass it over to Paul.
Thanks, Trevor. Appreciate it. And thanks, everyone, for being here today. In addition to echoing Trevor's comments, I really want to say that I understand, and we understand, it is by no means is it easy for anyone to be here today. It's particularly in the days that are simply so tough for many of us to wrap our minds around, what's going on, what's next, how will we make it through. So just know that we appreciate you guys just even taking out the time for being here. For those who I have not yet met, my name is Paul Reiser. I'm the director of Detroit Urban Solutions at Tech Town Detroit, and also co-founder of MedHealth and proud partner to many individuals and organizations here today on this call. So including the great partnership, as Trevor mentioned, with ScaleHealth. So just a little bit about MedHealth. MedHealth convenes innovators, providers, payers, funders, health systems, economic developers, and businesses, of course, to accelerate innovative solutions that improve the quality of care. Not just in Michigan, but also nationally and even internationally, which is in large part driven by our strong working relationship with partners in Ontario. So events like today are critically important to our mission of really can be best summarized as connecting, convening, and educating. And that's across healthcare communities and ecosystems, while really working hard to identify tools, solutions, and opportunities that can help address some of the most pressing challenges in healthcare. And so that's really what MedHealth is all about. And so with that being said, I think it's really also worth mentioning that we're really inspired, and Trevor touched on this a bit, to bring this event together today because of our work and support that's close to healthcare systems, to organizations, innovators, and many others in the industry. It was our belief that while there's an immense amount of deserving attention that has been applied to many victims and distressed communities impacted by COVID, we also turn to ourselves and ask the question around, well, who's taking care of us? Furthermore, how can we bring more attention to this topic? How can we share ideas on how to address this stress and this burnout that is being experienced by many healthcare and frontline workers? So how can we talk about the solutions that may work, but maybe even most importantly, how can we ensure that our healthcare heroes know that we truly appreciate them and care deeply about their well-being? So that's what we're really here for today. We have an amazing panel, and I absolutely encourage all of the guests to post questions in the chat, engage in the Q&A that we're going to have for the last 20 minutes or so of this afternoon's discussion, or morning for some. So let's get into it. We have, like I said, an awesome panel as well as an amazing keynote speaker today, Dr. Arash, who is going to kick us off. Dr. Arash leads the Wayne State University STAR Clinic. STAR is an acronym that stands for Stress, Trauma, and Anxiety Research. And you can find STAR in his lab, Dr. Arash's lab, at starclab.org. But just a little bit more about Dr. Arash. His clinical work is mainly focused on anxiety and trauma-related disorders, PTSD in civilians, first responders, law enforcement, refugees, and victims of torture and human trafficking. His clinic utilizes pharmacotherapy, also known as medication, psychotherapy, exercise, and lifestyle modification to help patients achieve their full capacity for a fulfilling, rewarding life. His research is also focused on anxiety disorders and trauma. So several research studies at the STAR Clinic examine the impact of exposure to war trauma in adults and children, Syrian and Iraqi refugees in the US, and even biological and psychological factors of risk and resilience. The STAR Clinic also researches neurobiology and psychotherapy and the utilization of even AR, or augmented reality, and telemedicine technologies for providing in vivo treatment for anxiety disorders and PTSD. Dr. Arash has a very special interest in the personal meaning of trauma. Or in other words, how does personal interpretation of a traumatic experience affect the way that an individual is affected by it? Dr. Arash's work has been frequently featured on CNN, NPR, Washington Post, PBS, American Academy of Child Adolescent Psychiatry, and tens of other media outlets. We are very privileged to have Dr. Arash with us here today. Please, everyone, welcome with finger snaps our keynote speaker today, or guest speaker, Dr. Arash. Dr. Arash.
Thank you so much, Paul, for having me and for such a lovely introduction. I really appreciate that. So as Paul mentioned, I'm a psychiatrist and I'm specialized in anything anxiety and trauma related. I work with different sorts and groups of victims of trauma, from victims of torture and human trafficking to first responders, cops and firefighters, civilians, and also we do the research that we are doing. Basically, the purpose of our lab has been to not be an ivory tower kind of research lab that is just like publishing papers, but rather be able to bring the insight from neuroscience world to clinic and make the clinical work better and improve the clinical practices. And later I can tell a little bit more about, for example, of our work in neuroscience and augmented reality and why that is that is our knowledge from basic neuroscience is helping us in that field. So we are talking about this pandemic, which has been a very unusual experience. A lot of times I tell my patients that at some point, like trying to put it in perspective, you may in future tell your grandchildren this was the worst experience of your life, the way that like other people talk about the time of war. So there are several elements in trauma and stress which make it a lot more painful and a lot more traumatic for any experience. One is uncertainty, one is transition, and one is lack of control. Uncertainty, basically everything was uncertain when we started this process. In a matter of weeks, we are told that we are dealing with a disease that we don't know much about. We don't know much about how it even spreads, and we don't know what's going to happen to our economy, to our life, to our work, to our personal life, to our social life. And then very, very rapidly we transition, just like for those who are an employee or an employer. Just imagine if you wanted to implement one change in your business, and you would say, okay, from I don't know, we are planning over the course of the next 3 months, we are gradually transitioning from this, let's say in our field, from this electronic medical record system to the other one. You know how much of a hassle it was. Now everything transitioned in a person's life, from the way we work, the way we eat, the way we work out, the way we socialize. We used to spend majority of our time with our colleagues. Now we're spending most of our time with our spouses and pets and kids. A lot of us are separated from our social support networks. And then there is the issue of lack of control, because all the control we had at some point was just sitting at home. And there is data coming from previous pandemics and this one that societies get really stressed. Rates of anxiety, depression, suicide, all those issues increase among populations. And as I go, I might just like, sorry, I apologize, share some links here, like about the data that I'm talking about. So for example, here's a link from the CDC about rates of stress and mental health issues and symptoms among general population. So now for a person working in the front line, imagine all of these issues are in place, like from all those aspects that we talk, losing all those potential ways of de-stressing yourself, and so much stress added to what is happening in life. And top that with a very contentious, painful, stressful, terrifying political year that we went through. So it's like all the bad things that we could get, like we got them together, regardless of which party you belong to and which kind of thinking you were to, because either side was terrified that the other side is going to ruin the country. So now for a person who is involved on the front line with the care of the patients, you have that plus all those aspects of stress in the workplace, meaning that I don't know much about how to treat this illness. There's an extremely high workload. We have transitioned to doing everything in a different way. Now we have to be covered, not me, because I'm a psychiatrist working, doing telemedicine, but sorry, those who are in the ICU. All the body covered, new protocols, new complicated protocols. You may be actually a psychiatrist who was dragged to the ICU because of shortage of staff, that you have to now do all the things that you never knew how to do, or you were not doing on a regular basis. And then the lack of control, meaning that as physicians, usually we have something that protects us against trauma and helps us, is a sense of control. You know that, okay, these are the ways I can treat. When a patient with terrible PTSD comes to me, someone who has seen horrific scenes, post-traumatic stress disorder basically is when you are exposed to something very, very horrible, like natural disasters, rape, assault, shooting, terrible car accidents, torture. When they come to me and I'm showered with the memories of these traumas they have gone through, one thing that helps me a lot with my mental health is knowing that I can help them, and this person in a matter of weeks and months can be feeling much better. But that was absent for a long period of time during the COVID. I mean, especially the first half of the year, when treatments were not solid. We were not sure about what would be the best treatment methods and what would be the best approaches. And basically, a lot of our healthcare workers had to just watch people die on a very unseen scale. Like if you were working in the ICU before, as anybody, and we don't want to just focus on physicians and forget about other people who have been doing all the work, nurses, respiratory therapists. The janitors in the ER are exposed to all those sceneries. The people who move the bodies, the dead bodies, are involved to all those scenes. And this is happened, let's say before this in the ICU, I don't know, every few shifts you could have one super old person dying, but now you are seeing multiple people on a day-to-day basis. And this has been very traumatic to people. And there have been surveys coming out showing a high level of exposure, the symptoms of anxiety, depression, post-traumatic stress disorder among frontline workers. Other groups who have been involved have been the EMT personnel who have to go to people's houses and bring them to the ER, have been the fire department personnel and the police force, because those also were involved in all these aspects of COVID. And every time you're dealing with the COVID patient, as any of these people in these roles, there's also risk of you getting contaminated. And even if you don't care about yourself and you are the most selfless person in the world, you know that next is your family is threatened. There were physicians who were living in the garage because they didn't want to risk their families with this. So it has been all these aspects and cumulative trauma. And cumulative trauma is a very important aspect of our research, and a very bad aspect of trauma. Because let's say I am assaulted and robbed on a street once, and after that I get some care and support and then come back to my normal life. I may develop PTSD, post-traumatic stress disorder. About 8% of the US population do have at some point in their life pass all the threshold criteria, meaning have all the symptoms of nightmares and flashbacks and avoidance and feeling terrible mood. That is part of life, but then I go back to my normal life. But for a person for these people, it was and is a continuation of months and months of exposure to these horrible scenes. That's the same thing that we see with first responders, with the fire and police personnel. Because I do also work with Detroit Police Department and fire departments. We see a lot of those on a day-to-day basis. Every time you're called to go on I don't know what they call them, on a trip or a mission, you don't know what you're dealing with. A lot of times I was talking to one of the cops because of the technology we are working on developing now last week, and they said the worst thing for him is the scenes of someone dying and they have to resuscitate and the family is yelling and screaming in terror and they're trying to save that baby. And this happens on a day-to-day basis. So in our department, what we have been, and the other thing is that the way, in general, the way that medical care is provided, this pandemic has also expedited a lot of changes which were already happening. Like in our department, we were already doing telemedicine. Half of my clinical time was remotely working with a federal qualified health center in underserved area of Detroit, treating patients via telemedicine. Now everything has switched to telemedicine. The good thing is that the insurances were forced to cover telemedicine care, and that actually benefits because there's a ton of research that shows telemedicine is equally effective to face-to-face, and satisfaction for the patient and the provider are also equal. And then it helps us actually special populations with limited resources. Let's say those people, let's say mother of several kids, a single mother with several kids who doesn't have a car, who doesn't have to go to the clinic, or in the winter of Michigan, or doesn't have access to childcare to leave the kids and go to the clinic for several hours, or people who cannot leave their jobs. So there have been also positives coming out of this. Like I have had much less rate of no-show in my patients because now everybody is a phone call or a video call away. And I have cops calling me from inside of the police car. I have moms calling me from inside the bathroom. I don't know, people calling from the lunch break. So what we have done also has been developing this program called Frontline Strong in our department, where we have been basically offering these services to our healthcare workers. Basically anyone with issues of stress, depression, anxiety that has been evolving during this time, and in general, healthcare workers are a higher stress population, who call, and we would social worker, therapist will screen them, and if there's any help they can do, they will provide, and if there's a need to do it for a higher level psychiatric care, then they would be referred to us. We have also been working with the emergency department at Wayne State University, basically having kind of a group sessions, meeting, chit-chat, therapies. And you got to remember that there's a joke that physicians are the worst patients. So convincing these tough men and women, same applies to the police and fire. It's just no, because the stigma, and the fact that they have to be in control and in charge, and it's hard for them to accept vulnerability. So we have had these discussions with the ED department on ways of developing resilience and on ways of coping with these kind of stresses. And now we are basically advancing these kind of services we recently got a contract with the Michigan State to provide these services. And we have been working to the first responders, including fire and police department, from education to counseling, peer support, and treatment. And a lot of these happen via telemedicine. I'm gonna The other thing we did during this time was like, so as was mentioned earlier, our lab has been working on the augmented reality technology. And basically the idea is that, so if you're afraid of something, whether it's a fear of spiders or because you were traumatized and like, I don't know, you have been in a shootout and now any loud noise or any crowded place creates a fear because of PTSD. Or combat veteran like sees a roadkill and that reminds them of an IED. So exposure therapy is a very good treatment. We basically gradually expose the person to what they're afraid of. And that fear goes away. It's one of our most effective treatments. The problem is that majority of people expert in this field are in areas around academic environments away from other people, from like not with lack of access in remote areas. Which can be addressed by telepsychiatry. But then the next problem is that if you came to my office and said, I'm afraid of spiders, I'm afraid of snakes, I'm afraid of dogs, I don't have spiders or dogs in my clinic. Even if I brought my dog to the clinic, that dog wouldn't listen to me and that would be just one dog. And then we cannot basically generalize this to all these different kind of breeds of dogs that you may be afraid of. And then that happens in my office context, and then you go home, because we have not contextualized it to real life, then the fear may come back. We have been, for all these reasons, we have been using augmented reality technology in our work. But I have to do the disclaimer that this is a project idea patented by Wayne State University. So there's a potential conflict of interest here. Wayne State Tech Transfer Office is involved. I'm gonna show you. And I know I have 5 minutes. I'm gonna show you some video of very quick video of this technology as where it is now, and its implication for the populations we are talking about. So basically, this is a technology we initially started the proof of concept for fear of spiders, which is a very common fear. And these are real patients. So they wear the AR goggles, and this is what they see in the real environment. The cool thing is that they will be interacting people with the real life environment. It's not as if you're wearing a AR headset and you're in a different world and you cannot even walk around because you will trip on on the coffee table. So I can place, so as a provider, I see a 3D mapping of the patient's environment. I can, from a drop-down menu, choose the object of fear. I can place it in the environment wherever I need to. And then I can see the black ring is where the patient's head is. The yellow light is where the patient is looking at. And all those arrows are the spiders I've placed in the environment. So I've basically become a movie director who directs the show and basically run the exposure. And this is the patient view, So these are basically, the cool thing is that these are very accurately placed on the patient's environment. So there is interactive. I ask the patient to go close to them, try to like touch them, try to like, I don't know, the spider will crawl from the table to the ceiling. It can, and we have different kinds and types. And this is how we tested the effect of the treatment, because at the end of the day, we don't want people to feel comfortable with virtual spiders. We want them to be comfortable with real. This is a real patient, and all of that guy, that little animal is Tony Stark. It's a tarantula, and everybody, like all of the people we treated in a clinical trial, in less than 1 hour touched the tarantula or the tank containing it, and that was the only one session of treatment we did. So we have been advancing this to fears of dogs, is gradually making our objects more complicated. And then fear of snakes. And basically the idea is to create a library of all the feared objects that therapists can use for exposure. So now when it comes to the situations that, let's say, a police officer or a healthcare worker has to deal with, and do we need exposure, is like, as I mentioned, scenes of dead people or people doing CPR on a person who's dead. So now we need more complicated human avatars that we have started working on. These are very, very, very primitive primary efforts that we have put in Nexus to use basically actors to act, and then we will create their avatars. And working on automation of these technologies so that the exposure can basically automatically happen on a patient's phone. And for that reason, we have been working on face mapping. During the pandemic, actually, we said, hey, well, because I also work a lot with the media, as Paul said earlier, I've been like talking to the media about how to deal with the stress of pandemic. We said, let's create an AR app for people's phones that they can use for free, and we can basically give them some tips about how to deal with the pandemic. And we worked on My Face because the idea was in future, we are hoping to basically create, if I have a therapist, we would create a 3D avatar of my therapist, and in between sessions, I would do home practices on my phone with the face of that avatar.
Quick, practical
and this is an example of the app that we had created. Basically, you can bring a 3D version of me and a dog in your living room and then listen to... and we basically developed this app in a couple of months. The idea was that we wanted to basically quickly send it out. So the quality may not be very excellent, but that's the way we are going. And I'm just going to share the link to that app and a couple of other the writings that I had about dealing with stress of the pandemic. And I'll be more than happy to talk more later. I think the last word is a pandemic. It might have caused transitions, but it might have also expedited the things which were already coming. One of them is telemedicine.
Thank you, Dr. Arash. Really useful information. And if we weren't afraid of spiders, we might all be now. I do just want to make sure that the links that you just dropped in, I think they just went to just us, the panelists. So I want to make sure that we can get that into that link in for the attendees as well. If one of our other administrators can copy that link and drop it in under panelists and attendees, that would be really helpful. So again, thank you. We're so grateful to have you here today. For those of you that don't know me, I'm Stacy Frankovich. I am the program manager for MedHealth here at TechTown in Detroit. And it's been a pleasure working with ScaleHealth to put this event together. So we're going to jump into our panel discussion. I'm going to bring Lisa McLaughlin, John Henderson, and Jeremy Fishbach on stage, if you will. And we'll get a little bit of a Brady Bunch thing going here soon. There we go. So what I'd really like to do is introduce each of you individually and give you a few minutes to talk about who you are and your technology or your role, and then we'll jump into some questions for everybody. So Lisa, why don't we start with you? Lisa McLaughlin is the co-founder and CEO of Workit Health. Lisa, why don't you tell us a little bit about you and about Workit Health?
Sure. Thanks, Stacey, and thanks, Paul, for having us. It's always a pleasure to partner with this group. So Workit is, my background is that I was a social worker who got a little burnt out and studied information science and started developing systems, and then have found myself building this company that's at the intersection of both. So Workit Health is a digital telemedicine platform that I co-founded with a friend in the Bay Area. We started the company because we were both people in long-term recovery ourselves and had seen a lot of people that we knew pass away since the time that we got sober at the end of the 90s. And most of that was due to having mismatch of care settings with people's lives and rehab being very poorly designed. So today Workit is a rather large and growing telemedicine platform. We have over 10,000 patients and work with healthcare plans across the country, predominantly in the Medicaid space, but really across all different lines of business to deliver confidential rehab to people's phones. And it's very exciting to share with this group and to share best practices.
Thank you, Lisa. We're really glad to have you here today. And I'm just going to go by what's on order of my screen. So John Henderson, you are the Vice President and Chief Information Officer out in California at Children's Hospital of Orange County. Would you like to tell us a little bit about your role and a little bit about your background?
Sure, thanks, Stacy. Yes, hi, I'm John Henderson, CIO for Children's Health Orange County. We are a pediatric health system with 2 inpatient facilities in Orange County, as well as 25 plus primary cares and another 30 plus specialty clinics. My role here is really all things technology, but it's also trying to bridge the gap between the technology that is beneficial and trying to make sure that we aren't introducing technologies that take away from the experience, not only with our providers, but also patients, et cetera. I've been in pediatric health IT the majority of my career. So I guess you could say I have a passion for the pediatric healthcare side and trying to impact that through technology.
Oh, thank you so much. We're so glad to have you here. And a conversation for another day is probably how COVID is impacting our pediatric and our children's population. But thank you for being here today. And let's jump over to Jeremy. Jeremy Fishbach is the the founder and CEO of Happy App. So Jeremy, how about you share a little bit about you and about Happy App?
Yeah, honored to be here. Thank you, Stacy. Happy is an innovative peer-based mental health platform. We have developed what we call a universal peer support model. So it's not focused on alcoholism or substance abuse or eating disorders, but really a very broad range of primary mental health issues: social isolation, loneliness, anxiety, situational depression. We have a national network of highly qualified peers. It's a very different model. Our peers have backgrounds in healthcare and are chosen for their ability to provide what we see as the essential ingredient of mental health, emotional support, exceptionally. And we have a lot of technology, mobile app, toll-free, inbound, outbound, all the purpose of which is to just enable people to connect and reconnect and build ongoing supportive relationships with our peers. And the ultimate goal is to have them build a new primary support system, a new primary mental health support system. As almost everyone knows, one of the main reasons we have so many mental health epidemics, isolation, anxiety, depression, is that we have an epidemic deterioration of people's primary mental health support systems. And so we're trying to address that epidemic at the roots. We're partnered with the largest Medicaid plan in the country now, Centene WellCare. We're going to be rolling out with a few other major payers in the next few months. And we're partnered with some large hospital systems. The American Nurses Association is their official peer support partner. And so, we see Happy and services like this as a resource for vulnerable populations and for frontline workers and really everyone in between. And honored to be here with all these distinguished panelists. So thank you.
Well, we're very grateful to have all of you. And why don't we just, with that, you all have such a different area of expertise that you bring to the table. So we're going to jump in. Some questions might be more designed for one of you or another. I know it's hard when you're in Zoom to talk over each other, so we'll kind of figure it out. But the questions that we designed today were primarily for your discussion. I would like to fall into the background here and not have be too much a part of the discussion, but let you all discuss. So for our first question, really designed for all of you, is really what is the impact of this COVID trauma that you have seen specifically in your areas or through your technologies? And if you have some specific examples of anyone in the frontline worker space that you can reflect upon, that would be great if that dialogue could take place. So whoever wants to start, I'll leave it there.
I'll just say to relieve everyone else's anxiety about going first that, a couple points. I mean, one, social isolation, loneliness, mental health issues, as everyone knows, long preceded COVID and may have been exacerbated by COVID, but we're here long before this. And so I don't want to, I think we need to give COVID its credit in really making life worse for a lot of people. Of course, it brought a lot of people back into their homes where they could actually connect with family members more as well. but it has certainly made things worse. Our partnerships, I'm sure everyone else has examples with, for example, American Nurses Association, Ochsner Health System in Louisiana, were specifically catalyzed by COVID. And as Dr. Arash was saying, just the increased burden on frontline workers. My fiance is an EMT, and I just started noticing that every day she came back from work, she was talking about seeing people dying, and also just those people dying alone. So in addition to just the trauma for frontline workers, I mean, just the trauma on their families from not just experiencing death, but experiencing it alone themselves. I mean, just horrifying. So I would certainly say, yeah, we'll be happy to see this pandemic, you know, hopefully in our rear view mirror soon.
Yeah.
I'm happy to go. So I echo a lot of those same reflections on seeing actual nurse practitioners that are on our staff, and PAs, MDs that work moonlight with Workit, but also work in emergency departments. Just seeing an enormous strain on those individuals in their sensitivity during their time with us after having been through these traumatic experiences on the weekends working in these shifts has been really alarming. But for our case, it's quite unusual because we were already dealing with an epidemic. So Workit focuses largely on the opioid crisis and doing more intensive care for individuals with opioid use disorder and alcohol use disorder. And we had started to see some gains before COVID in that crisis. And so seeing numbers starting to go down, a lot of coordinated efforts across government, health systems. And then when the pandemic hit, there's just this huge influx of when they now are in a twin pandemic, right? So numbers went up again last year to 86,000. We thought it was a huge crisis when it was 70,000, which is more people than died in the Vietnam War. So it's just gotten to be of epic proportions, but like on a more like silver lining side of things, which I hate to, you know, talk, it's hard to talk about the silver linings, but I think to Dr. Arash's point, the gains that we have seen in comfort with unique models and telemedicine have been catalyzed by being in this crisis situation. And so whereas like 2 years ago today, we would have been like fighting hard for like very simple things in addiction care, like people being able to have access to care from the home if they couldn't go out or if they had a DUI and couldn't drive. Today, those things are all possible because of a lot of the regulatory changes that happened. And that's actually been a miraculous thing for the space. Like we've seen telemedicine for addiction care become like a real standout case, like stroke. You know, there's certain cases where we know now that telemedicine actually works 30% better than brick and mortar care because of a certain kind of situation. Someone has a stroke, they're at home, they need to be monitored. We've been able to identify certain forms of addiction care that fit that. And we probably never would have known that had it not been for being like propelled into a situation where everyone just decided to suddenly permit telemedicine and not think that telemedicine groups were lower quality or meant that you were sending your patients to kind of a suboptimal middle of the road solution, but that they could actually excel and exceed expectations. So that on our side has led to our group quadrupling in growth in a year, which is, I think, been really exciting in a lot of ways as well.
So Lisa, you're totally jumping into some of the questions we had, you know, a little further down the line, which is great. So if you don't mind, let's kind of just stick with that whole topic of telemedicine actually working, because Dr. Arash, you and I spoke recently and you were talking about some data that was coming out of telemedicine as well, and that you're finding that you know, the telemedicine options for psychiatry are working just as well. And I also want to bring John into the conversation and ask what he's seeing from a telemedicine perspective from Children's Hospital in Orange County, and kind of some of the data and the results that you're seeing. And then I'm going to throw just another question into that long extended question. Lisa, you made reference to some of the policy changes that have allowed for this telemedicine. Do we think that's permanent? Are these permanent changes, or do we see them just being implemented as a response to COVID? So there's a whole lot there that I just asked. So anybody jump in and let's keep going down this path.
Sure. So I'll jump in and just talk a bit about the telemedicine aspect on the pediatric side. I think Dr. Arash mentioned this earlier. It really was a catalyst for us. We were probably doing maybe 200 telemedicine visits a year. We quickly transitioned within a couple of weeks of kind of the shutdown and stood up a program, and we're seeing 600 patients a day from a telemedicine, telehealth perspective. We've kind of leveled out a bit. We're around 360 per day now, but that 600 per day lasted for a good 4 or 5 months before things started to normalize a bit. It's been tremendous. We've seen some of the things that, Dr. Rush may speak to, particularly our psychology clinics, where they have seen a tremendous amount of benefit. Being able to see kind of the social, kind of what does the home look like with some of those visits gives them different insight than what they may normally get in the clinic when you ask those similar types of questions. Same thing from our primary care providers who are doing those visits. It really gives them a completely different level of insight to help with the care that they're trying to provide. So it's been tremendous for us. We think it's, for us, we hope it's not just a reaction, and we see this as a continuing business model for us. It's something we wanted to be able to provide to give us more access and provide more access to the pediatric population, and we see that as one of the big benefits for us.
So I'm going to try to just combine an answer for both of the questions you had. So the last year, with a colleague, we wrote a piece about how the humans, as advanced as we are, we seem to be having difficulty understanding abstract concepts. Like when the COVID was evolving in China, to us was just a story. When it hit Europe, it became like the movie pandemic to us. We still weren't much amazed by it. And then when it came here, we had to, as the most advanced medical system in the world, we had to see it right here, setting everything on fire for us to understand. It seems like abstract concepts are very hard for us to understand. And I never forget this example, with the former president, it was just downplaying until one of his close friends died. And it was oh, this is crazy thing. So we need to feel it here before and I bring this example because for us to be able to understand what happens to those frontline workers, we are just talking, when we are talking stats and numbers, and okay, 10 to 20% PTSD, these are just numbers. The reality is that if anyone is interested, just look up my last name and Aching Blue. I wrote this piece about the police trauma. Applies to all of them. Imagine they bring a person, a young adult, healthy to you, and they're suffocating in front of you and they're dying and you cannot do anything about them while you're terrified. You may get the disease and take it to your 80-year-old mother. And this happens on a day-to-day basis, every day, 10 hours, 12 hours, and your boss is also yelling at you, and you're short-staffed because a few of your colleagues got the COVID. And there was a lot of demoralization in these groups, and the healthcare workers not also feeling appreciated. Because I'm in the physicians community, people were feeling terrible that they are just putting their life on the line, and there were others who was the pictures of people partying on the beach were coming out. So this is one aspect, but when it comes to telepsychiatry, when I came out of my training and I came to my new job about 6 years ago, when I was Wayne State Psychiatry already was doing telemedicine, and we had a telemedicine operation working with the clinics, with the ER, with even substance use rehabs. And my initial knee-jerk reaction was that no, it shouldn't feel as real as in person, face to face. And then they presented me with data that showed telemedicine and face to face in terms of efficacy, satisfaction of the provider, satisfaction of the pain, they're neck and neck, and it's equally effective. And then looking at special populations and less privileged people who have difficulty with access, I had at that time patients who were driving 4 hours to come from a remote area in Michigan to see us in the clinic. So now that is all kind of gone. And it has been as effective as we all mentioned. We have had a higher number of visits and lower number of no-shows like before this, and especially the low socioeconomic clinic that we were working with, because of all those difficulties of access that I mentioned. We had about 40-50% no-show. Now it's like much lower than that. And I brought the idea of us being like a difficult species in dealing with realities and change. I brought that because like before this, a big chunk of disagreement with telemedicine was the inertia we have anytime something new is introduced to us. We don't want the new things. We want things. We have an inertia as a group of as humans. We need another bigger fear, like a lazy person sitting on the couch would leave the couch when there's a dog attacking them. We need this COVID to expedite this process. It makes sense. I don't see a way this going back. All I see, I mean, there probably will be people who prefer in person, and in-person treatment will be available, but this is going to be the future. And with other technologies, I don't know, with the technologies my lab is trying to throw in, mixed realities and VR, things maybe look very different soon. And one of the complexities will be like, is this going to turn into like the way like the big corporation chains of grocery stores are eating like the mom and pop shops? Is that something that's going to happen to like a medical practice or no? These are like all these challenging questions that will come up.
Well, that's, yeah, the future of healthcare is obviously changing right before our very eyes. I'm going to drill us back in a little bit though to those frontline workers that, as you mentioned, Dr. Arash, too, some of them have had to go home after a difficult night and deal with friends or family members that think COVID's a hoax, or actually having patients' families yell at them or say things to them because a family member is losing the battle and they don't believe it's COVID. So we do, not only are they overworked and they're fighting this battle, but when they leave at the end of the day, they're almost fighting a different battle with those that are struggling with their belief on what this is, and seeing the images of people partying on the beach and all that. So let's go back to those frontline workers. And John, maybe you're in a good position to answer this, because I'm sure at the leadership level of the hospital, you're having conversations about how do you address this within your, employee base? How do you, we had high instances of physician suicide, physician drug and alcohol abuse before COVID. We had high instances in the nursing community. We were dealing with a nursing shortage prior to COVID. So, how, from a leadership perspective, is Children's Hospital of Orange County looking to address their employees' needs?
Right. Thanks, Stacey. In a variety of ways, I think a lot of times because the pediatric population hasn't been as impacted as the adult, I think sometimes there's a tendency to think that, well, maybe it's not really happening in those settings, but it is just at maybe a smaller scale. I think some of the things that, we've seen lower inpatient volumes because of the pandemic. And so, while, obviously that's not what we had projected, but it also has helped in a sense from a staffing perspective in kind of that round the clock component. We've had to deal with caregivers getting COVID and short staff and those sorts of things. So some of the things we've tried to do, we do a tremendous amount of town halls with our chaplain service, with our providers, our clinicians. We do a lot of town halls with the leadership team, with the whole organization, really just to educate and say, here's what we're doing. One of the things that we've been really mindful of is trying to make sure that we educate the community about how safe our hospital is and the protocols we have in place. And so, that's one element, but really the outreach with our providers and nurses and clinicians, and just trying to keep them informed and really giving them a space to share their concerns and be able to be in a position to say, well, here's what we can do to solve or work on this particular area where you have a concern, whether it's the equipment, whether it's our screening protocols, or whatever the case may be, giving them space to voice their concern. That's been really important, and we continue to do that. I think one of the other things, some of the other things is really just continued education. You mentioned the dynamic of having to leave after providing care and interact with the rest of society who may not share the same belief about what COVID really is or isn't. We've just tried to do a tremendous amount of education. Our infectious disease chief and providers, they've been doing a tremendous amount of education and just providing us with all of that information to help with that. I think one of the things that I mentioned earlier with our chaplain services and some of our mental health professionals, just making those things available has been really important for us as an organization to make sure people have those resources to access, even to kind of just help them work through some of the challenges that they're facing.
Fantastic, fantastic. And then to you and to Lisa and Jeremy also. So, you know, as innovators from the outside in, looking at the health, you know, the frontline worker, the health community, have you seen changes in the way that your technology is being used for that population? Is it something you're even tracking? I mean, I don't know for sure if that's something you're even tracking, but has the frontline healthcare worker, or even, and I say frontline healthcare worker, but we're also talking about police and fire and, you know, just those first responders that are coming into the apartments and are terrified to try to transport somebody who is contagious and they're fearful. So are you seeing any type of increase in usage of your platforms from the frontline perspective?
We definitely are. So at Workit, we have partnerships in New Jersey with the New Jersey Police Force, so NJ Cops, as well as first responders groups. And there, I think it's been really wonderful to have confidential, discreet care available to those members, especially because at such a controversial time in policing, like really many different types of responders are under a really high level of trauma right now. And we've seen a lot of gateways to even harm reduction approaches in substance abuse for clinicians, which never would have been there in the past. In the past, it would have been very punitive. It would have gone directly into a compliance program and been kind of at risk of losing your medical license. So that's been good to see companies get really modern about how they think about their workforce in these first responder groups as inevitably undergoing trauma and as such needing care, oftentimes care that could be stigmatized in the professional side, and changing their perspective on that has been super powerful.
Thank you. How about Jeremy? How about you?
Yeah, I mean, I think we've seen really two things. One is just heightened awareness that frontline workers need more support. And in a lot of our conversations, whether it's with large membership organizations, American nurses, or large health systems, you know, they know that 30 or 40% of their workforce needs support, and that with existing EAPs, they have 1 or 2% utilization rate. So I would say that the main thing we've really seen is a shift, in at least our conversations, from a focus on the accessibility of resources versus adoption. Right now, there's actually a lot of resources that are available to people if they want to avail themselves of them, and they're not. And we hear from all the organizations we talk to that there's a huge discrepancy between the need and just actual utilization numbers. We've innovated a lot in doing much more proactive, a much more proactive approach. And we've seen our own engagement rates go from 1-2% to almost 35% in populations as large as tens of thousands of people, or in the case of a health plan, a couple million people. And so a lot of it's just been innovation that we've had to push to really focus less on what we think is just a much lower barrier to just have resources available if they're not being used, it doesn't really matter.
Right. Have you, both you and Lisa, have you struggled at all with scaling to meet the need?
We've invested, I think this is where our technology background has been extremely helpful. Like a lot of our investments to meet this scale experience that we're undergoing have been in optimization of provider workflows. So really investing in note-taking within the EHR and automation of assessments, things that will help our clinicians spend more time in care and less time in the burnout of assessment after assessment after, we're all on these on-demand calls all day like we are here. If you're experiencing that as a clinician, and then at night going home and filling out 30 assessments, whatever it is, like that's an added burden that's not really about the patient-clinician relationship. And so that's where we've invested in scaling and has enabled us to have like higher ratios of care, enabled the system itself to do some of the lift and the compassion fatigue and like automating referrals, automating different things that would normally be an additional step for an already burdened provider that really just wants to focus on their real analysis of what's going on with patients.
Mm-hmm. Mm-hmm.
Yeah.
Jeremy, any issues?
No, we haven't. I mean, our technology is very scalable, and we have tens of thousands of people who are in queue to be one of Happy's support givers, and we have a very streamlined vetting process that takes about 1/100th of the time for that it takes for a traditional peer program. So we haven't had issues.
That's great. That's great. So as much as I could have this conversation with you all day, but I do know we have a few questions coming into the Q&A. So I'm going to ask kind of this last question before we jump over to Robert and have him moderate some questions from our audience. And it's kind of a two-parter. So what do you see, and maybe this is for Dr. Arash and Dr. Henderson, as far as what do you see as far as any policy changes coming or any gap areas that are coming down the pike that might need solutions? And then kind of for all of you, some final thoughts on where people can get help, how people can get help, or how technology is really being positioned to help. So it's kind of this big, bold last question, but it's kind of these last thoughts about where you see this going. We do have, I'm looking at the attendees, we do have quite a few individuals in our attendees list that are actual entrepreneurs, innovators that are looking to help solve problems and are looking to meet a demand. So I'd love to hear kind of what you think is next down the pike, if you will.
So if I may start, as I mentioned earlier, I think telehealth is special in the field of mental health because we don't necessarily have to physically examine our patients. As is gonna stay, there might be a battle between insurance services and the regulators to allow that because of two reasons. Number one is like the ease of it. And of course, when it's easier, it's more accessible and there will be more utilization. So I don't know the data on how much insurances have been paying more or less this year compared to the last year before in terms of telehealth and telemedicine, but that could probably be the only limiting factor because otherwise, with the current state of technology that every kid has in their hands, telepsychiatry and telemedicine is doable. I mean, what is interesting to me is then the next level of automation of some of these services. Let's say I do telemedicine, let's say, and I'm going to talk about my passion of AR. Let's say I bring a patient to my clinic, they wear the AR headsets, and then we do exposure. And let's talk about a simple scenario of like dogs, or like a more complicated scenario where I have created like an ER with the patient very sick, dying, and the frontline worker does the exposure or practice. And then when they go home, they will have their mobile app. And that part of it is like how these mobile devices will be advanced in terms of mixed reality and AR and face spatial mapping. And then you will have, because a lot of these treatments we are offering are manualized, they are algorithms which can be learned by AI. And basically an AI doctor, an avatar of myself with similar to my face will be basically say, okay, now look at this little like a puppy Labrador, and we'll next stage we'll do this and we'll do this. So basically, patients can do home practices via those kind of technologies. And I think when we move a lot of what we are doing to handheld devices, or handheld devices, who knows, will turn to glasses that people wear at home, this will explode like any other area of our life.
You know, I'd like to build on what Dr. Ross mentioned. I think the AR VR component is, we see a tremendous opportunity. We're doing some things with that today, with kind of diversion from pain as you're doing procedures with some of our patients. But there's a much larger applicability to it through all types of care. So we think that's going to be really big for us in the future from a care delivery perspective. Also, even from an educating our clinicians using that technology. So we're very interested in moving some of those things forward. I think obviously telemedicine in all of our domains are going to continue to be a key part of our model. We're really focused on the wellness and prevention side. And so, you know, what the insurance companies and providers, you know, kind of where they go, that'll really be interesting. But we think the prevention piece is what's most important. And so we'll have a focus there. Data is always key, but I'll say at the point of care and really becoming more automated with really strong algorithms to help make it easier for the clinician and provider. You know, you talk about burnout, you know, everyone always talks about the EHR, and it is a challenge. So I don't want to discount that, but we have to make those things easier. And I think part of making it easier is with automation, with AI, with machine learning capabilities, making those things that providers would normally have to find and search for, eliminating those things. So it's just there for them, or it's actually providing them that information, whether it's voice assisted capabilities. Those are the things that I think are really what the future holds for us.
Thank you. And we have a company that we've worked with here that I do believe, somebody will correct me if I'm wrong, but I do believe is in an incubator or an accelerator program, maybe through Children's Hospital of Orange County, that's working in augmented reality for pediatrics. So, so there's definitely a connection there, and pain management and things of that nature. But thank you for that. I appreciate it. And Lisa and Jeremy, what do you see coming down the pike, and you know, what kinds of things are you looking to expand upon or grow upon with your businesses?
For us, we're really excited about the consumerization of healthcare. So Workit really was born out of this idea that like people were finding addiction care all wrong, and that like I had trailing Facebook messages from people who popped out of the ER and overdosed because our system for front dooring the experience is broken. Like John was saying, like I think essentially having members have the power to drive their own care and understand the care that they're driving is the key to the future of healthcare. So in our case, that means we are developing chatbots, and we are using algorithms, but we use those largely in the service of care orchestration and care driving by patients to like help our patients find. We have over 773 CBT courses in our platform. In the past, we would have had a much more passive approach of each individual clinician will bestow each patient with a course that they picked just for them. And we see the flip of that as being, you know, a machine can tell way better than any of our clinicians can tell when somebody's triggered because of travel and needs a travel course, or when someone's triggered because they just had a divorce and need a whole set of things around that, or their labs discovered they have Hep C and now they need to understand that condition. And the more that we can build these tools so that it reduces the burden from the providers and lets the patients feel like they're in charge, I think the better. I think patients are going to demand it, especially younger patients. And we're excited to push the envelope there.
Oh, thank you. That sounds great. Thank you. How about you, Jeremy?
Yeah, I mean, I think Happy probably has a unique and maybe seemingly old-fashioned view of things. I mean, I don't think it's really in contrast to Dr. Arash or what Lisa or John are saying, but I think our goal is to the extent possible, to be frank, take technology out of healthcare in a lot of ways. I mean, a lot of the people using Happy don't have an app, they don't have a smartphone. and their whole experience of the resources with a person, an actual human being. And I guess my own personal experience with healthcare is just increasingly spending less actual time, getting less actual undivided attention from healthcare professionals, and to have, and most of it is just people getting my data. And so, you know, we have very sophisticated communications platforms and ways to push and pull data with health plans. But from the people using our services perspective, our goal is to really bring a much more human touch to the experience. And I don't think that that's I think these are all great ways to advance healthcare, but that's certainly where we plant our flag.
Well, I'm thrilled that the conversations are happening. I cannot tell you, in the last few weeks, several weeks, I've seen so many different platforms coming forward to have the conversation, different webinars and different roundtables and different conversations to try to remove some of the stigma, address the fact that we understand there's need out there, and that all of you are looking at this from real progressive open eyes and looking for solutions. So I know I went a little bit over on my time, so I'm really sorry, Robert, but we have some questions in the Q&A, and thank you for this conversation. I could go on all day, and I won't. But we're going to introduce Robert Plush, who is, and I want to make sure I even get your title right. So you're the head of partnerships for ScaleHealth, and you're going to jump on and you're going to facilitate some Q&A from our audience. I see we have some questions there, and I will leave that to you then and find my way off the screen. Thank you, everybody.
Awesome. Yeah, well, thanks, Stacy. Yeah, it's great to hear everything that's been said. Certainly thank the panelists and for those that are attending. If you guys do have any other questions, we have a few questions right now. Please certainly go to the Q&A and post them. With that being said, though, I'll start with the first question. To some extent, this was already answered by Dr. Arash and John, but I'd love to still hear your thoughts, and then for the other panelists as well. This question is around the solutions that have been discussed in this, just in our conversation here. A lot of it has been around the teleconnection with people. And so this person is wondering if there's been any studies around AI and avatar-based interventions or support.
I think there's quite a bit of research in this area. Like, we look at this research all the time to see how far it's come along, because I was an early skeptic, thinking that exposures, as someone who was in recovery myself, that exposures in our space, in the behavioral health space, like walking up to a bar and turning down a drink would not be as effective as the smell, the look of, like, the sensory experience of really turning down a drink in a setting with a bunch of friends having a great time. And so I've always been skeptical, but I've been surprised as we've gone along. One of our advisors has been Dr. Itai Danovich at Cedars-Sinai, who has done some compelling work with AI and in addiction. So we always monitor the space. But in my view, what's most promising is interventions that have been tested in other spaces that aren't necessarily healthcare. Like, there's avatar apps like Replica that are not even necessarily designed as a healthcare app, but that are doing amazing, proving out amazing usage, and that a ton of people will use a virtual avatar as their primary support. And that really makes a lot of sense, because a lot of this stuff is about privacy and confidentiality. Like, these are stigmatized issues. So the idea that you would actually talk to your robot friend and tell them all these intimate things without fear that they're going to share them in the community, it follows pretty rationally. And so I'm excited to see where it goes, but excited to hear my co-panelist dig into this one.
Yeah, awesome. Any other thoughts?
I'll add in just a bit. I think there's not a tremendous amount of research on the pediatric side of this, but what we are seeing with just the things we're doing, it is tremendous. Kids are into this sort of technology in their personal lives, so it's a natural for us. We see just as a natural way to enhance the care and to have them be more comfortable. So if you think about surgical procedures that a pediatric patient may have, if you can walk them through what that's going to look like coming into the hospital, similar to what Dr. Arash was showing us, you walk them through those things. It helps decrease their anxiety about what's getting ready to happen to them, because it's already a stressful situation anyway, not only for them but also for their parents. And so, just the applicability of the impact, the positive impact on this, I think, is just tremendous.
I actually really liked Lisa's approach of seeing, oh, is there any other area where these avatars are working outside of healthcare that can be expanded? And I immediately thought, yes, gaming industry, and see how many hours doesn't have to be a kid, a 50-year-old adult sits and interacts with those avatars, and it's part of their real life. So it seems like they are applicable, and one of our thinkings when we were thinking about like creating an avatar of the real provider has been like, because there's a rapport between your provider as a real human, then you might be able to create their avatar, kind of transfer that rapport and trust and continue. But I think, yeah, that this is an excellent question, and a big chunk of our future might be like, I just give patient an app, and then the app is automatic, like the AI is leading them through steps of, because anything that has an algorithm can be automatized. And a lot of our treatments, especially when it comes to the fields where we do exposure, they're very straightforward. Like in psychoanalysis, it will be much harder, but in these areas that we are working, it will be easier.
Again, just going back to the AI and these avatars, specifically around just healthcare workers and burnout, a lot of adoption of things in hospitals certainly has to do with ease of use, and the integration of that into just current workflow. And so how would you see, is there, this can't, we can't expect that, a clinician, or frankly, anyone that's working in a hospital is probably going to spend an hour with some avatar thing to decrease their anxiety. And so, is there any thoughts around just utilizing this type of technology where it's integrated into either current workflow or the access is easy, where it can be utilized in some type of short time frame where it really moves the needle, and might help with anxiety and help with burnout, where it's not necessarily disruptive?
Sure. I think, the physicians that I work with and the ones that are really interested in this, they see value in it. They see value in not only for their patients, but also how it may help them get back time. I think Jeremy talked about it earlier. One of the main things, a key part of my role is we don't want technology to be a barrier for the treatment and for the quality time that the physicians want to spend with their patients. And so that's something we have to constantly focus on. So I think as long as it's going to do that, if it's going to give them time to focus on the care, then the providers are going to be very interested. But to your point, it has to be integrated really seamlessly into their normal workflow of care delivery. And that's always the most, the challenging piece, is figuring out how to make that simple and easy for them. But it's definitely doable.
All I can add is that like we recently have got some fundings from MTRAC to package what we have been doing all this time to something which is usable by the clinicians. So we'll be spending a whole year to talk to all these different clinicians to see, because technology always brings the resistance. Like how will it be the most easiest use? And I always, the example I use is for my because I have like one of my programmers, he's super brilliant and super, like he's always in the clouds. I'm like, imagine your end user is an older social worker sitting in their private office, and see if they would be able and inclined to use it, because we have a lot of these technologies. Like VR is already out there, but not many clinics are using them. So being like being able to show in my research lab that something works in a controlled research situation is one thing. Me being able to show that other people in a private clinic are not only able but also interested in using it is a different story.
Sure. Awesome,
helps
awesome.
to have like a cross-disciplinary team where you put the clinicians at ease and you're all working together. So we have like the engineering team daily working with our nurse practitioners and doctors, because otherwise I think you get what I like to call like the Napster effect. You get this fear that like the organization is productizing or completely replacing the clinicians when we're trying to help them and trying to make their lives better. It's like, are you automating my job? It's like, no, we're not. It's like we're amplifying your job. So I think you have to get past that nervous system fear that people have that times are changing and they're going to turn out to be the blockbuster in a world of Netflix. And it doesn't have to be that way.
No, great point. Great point. The next question is around the attrition of healthcare workers. And so obviously there's a shortage of nurses. That's been going on for a long time. There's a shortage of physicians, and that's anticipated to grow. And so this question is around the attrition of healthcare workers is due to COVID. And if so, what are your thoughts to rebuild the caregiving workforce? And what actions are being undertaken now to try and hedge this?
So I'll take a leap. I'll take my first stab. I'd be interested in what Dr. Arash has to say. I think it's more a structural national issue, to be quite honest. It's so expensive. And so it's a deterrent now. And so I think, that's one big element of this. I mean, even beyond just medicine, just attending college is extremely expensive, in this country. And I think if we don't really address that element of it, I think that shortage may continue. But I think one of the other things that I think is important is, how do you get to kids early enough to get them excited about being in this field? I think that's one of the other elements that I think we may be missing the mark on. And so, you have a couple of those scenarios there. If you can try to impact them in those ways, then I think you can kind of help shift that trajectory. But it's definitely a tough time. What do you say?
I mean, anything I say is just hypothetical because I'm not in the management roles who makes those decisions. But I mean, they have been yeah, we clap for them and we just say, oh, the frontline workers are awesome, and we talk about them in the media and stuff. But at the end of the day, a loan forgiveness program for, let's say, who go to nursing school might be more helpful. And I agree. I mean, it's a philosophical discussion that John briefly mentioned. I believe in America, the problem is that healthcare is a business rather than a service. And that in a business, your top priority is revenue, is not the service you're providing. And that is one of the reasons that our healthcare is so much focused on treatment rather than prevention, which could really, really lower costs. So we are not working on lowering costs. We are working on creating revenue, which is a big problem and way, way, way above my paycheck. And in fields like mental health care, it's even worse because we really, really have a shortage of psychiatrists. Right now, any of the academic centers like University of Michigan, Wayne State University, Henry Ford Hospital, you can find a faculty position as a psychiatrist, which would be a dream job for a lot of people. We don't have people who can provide these cares. I mean, there have been a more rush of, there's some hopeful signs in my field is that there was a time that psychiatry, because we didn't know much about how brain works, was the thing that physicians would only go if they couldn't become something else, a lot of people. But now with all the advancement and developments in the neuroscience and understanding neurobiology and good effective treatments, we are seeing more and more and more and better doctors are going to this field to become psychiatrists. So this is good, but the problem, especially the way it goes with telehealth, the need will only increase. We will have more people now having access to the care that they didn't as easily before. That's very good sign on the other side, but on this side, in terms of supply, I don't know.
For us, we have found that returning to the joy of medicine for our clinicians, once we engage them in system design and actually building stuff, they geek out on helping to build the platform, and they feel reconnected to what drove them into medicine in the first place. And so the more that we engage our healthcare workers with the design team, which took a long time, right? Like the engineers were like, I don't want to talk to them. They have a completely different way of thinking. But now that it's working, I think it helps with retention, because I can see difference between the clinicians that are engaged in that work and those that are just working with us on a moonlighting basis, part-time basis, just doing the clock in, clock out, and the appointments. They're suffering from that commodification feeling of healthcare. Like, have I become, Henry Ford's version of the auto worker on the assembly line now? Have, like, that feeling, I think, really hit a lot of people during COVID. And they just didn't want to, A, risk their lives, and B, just like be a bot, be a human bot of medical delivery care. So I think we have work to do as a society to get back to the joy of this work and like the discovery pieces.
Awesome. Just one more real quick question. So, I mean, obviously, when you think of healthcare, obviously there's the clinical side of things. With regards to like burnout, there's a lot of operational potential technologies that could be brought into healthcare that might ease the stresses around healthcare, around with the clinicians. And so, are you guys seeing, like and I don't know if this is more of a question for John and Dr. Arash, but even for Lisa and Jeremy, like, are you guys seeing, that they're, when you're looking at the overall aspect of healthcare, and to your point, Dr. Arash is trying to do more preventative care, there could be, if there are more operational, if hospital systems, and again, I know they are, but, if they were to bring in more operational solutions, do you see that like easing some of this burnout issue and making things easier, so the people who want to be clinicians, whether the nurses or doctors, can really focus on the clinical care and not have to worry so much about the all the administrative aspects, of their jobs?
It's a good interesting question. I think the EHR, as I mentioned, there's challenges with that, but even if it's the best and you've optimized it, there'll still be some challenges there. So I think there's a couple of things. Education and just-in-time efficiency. That's been one of the things that we've seen from some of the surveys that's really important for physicians. The ability to know how to use this technology as efficiently as possible, so that they're not wasting time. And so we see value, and they see value in that. We've seen some where we've done that and provided kind of just in time, watching them work in the clinic, and then giving them tips and say, hey, we saw you navigated this way to get to the chart review. If you go this way, you just eliminated 4 clicks. You're only going to have 2 clicks as opposed to the 7 or 6 that I just saw you do. Those things are impactful and important, but I'm going to say what I'm seeing, or what I've seen across, is the incentive. So it's time. So I think Dr. Arash mentioned it's a business, so volumes matter in a lot of cases. So if that's the key driver, then you're going to have less quality time, because you're trying to see as many patients as you can. That doesn't always equate to quality of the visit. And so for us, I think Lisa mentioned the joy of practice. Our executive physician over our primary care, he always uses that phrase. That's really important for him and his primary care physicians. And so trying to make sure that they have the time, and that you're structured so that you can create the time for, I have administrative work to do, but I have protected time to do that. And that's not bleeding into my time for delivering care. So I think those things have to be addressed.
I think it's interesting that our thoughts both went to the same place when we were listening to your question. Well, I think if you ask any person in healthcare work, physician, nurse, what do you hate most about your job? Probably on the top 3 list is working with the EMR and EHR. You have to, because I have to work with 2 or 3 different EMRs based on all these different clinics I have to work with, which means I have to learn all these. And then just an example, if I have to do a renewal of a prescription of, let's say, an ADHD medication, which is a controlled drug, which I have to write every 1 month for a patient who's constantly taking on this medication, I probably have to do 8 or 10 clicks and enter and type in like 3 or 4 times to be able to renew one prescription of a one ADHD medication for one patient. Let alone when the documentation, you have to enter the billing code, you have to enter this, that, and sign, and like that, sometimes signing doesn't go through, you have to do it again, a code someone has to co-sign. So if that can be automated, if someone, and I don't know why, because like Microsoft Word, which is the stupidest software, while it's the simplest software among all these softwares, EMRs are the most stupid like systems to work with. If someone can automate these, like to the level that, let's say they can even like, I can like it speak, and it will just turn it to the documentation, and then I say renew this prescription and that prescription, and things are done, we will be a lot happier, and I'm sure they will make tons of money.
Great.
So I'm on screen because I'm the buzzkill that because we got to wrap this up, and I want to be thoughtful for our attendees' time and for all of our panelists' time. So I'm sorry to be the one to come in and say it's getting to be that time. I did put a little note in our chat. So if any of you have resources or anything that you can drop in the chat where people can get help, because at the end of the day, we really want to make sure that people have access to help. Also, we can, we'll drop that into any post-event communication and make sure that people understand that help is available. There's places to get help if they need it. And then, you know, Robert, and please jump in, but I can't thank you all enough for participating with us. It's been such a pleasure to have you here, and I can think of 10 more conversations I want to have with each of you. So, sure. You know, Robert, why don't you jump in and say a few words as well?
Yeah. With that being said, I mean, obviously, you know, for the panelists, they have their website. So for those that are in attendance, please check them out on, you know, on their websites. You can always look up ScaleHealth.com and MedHealth, you know, for our resources. There's a big push that we're working on in conjunction with MedHealth around working with our partners to provide them great solutions. And so, you know, if anyone has any particular needs, you know, we have a global presence, and we've been able to have a lot of success with accessing really great solutions as well. And so, but with that being said, yeah, I mean, this was fantastic. Certainly appreciate the panelists for your guys' times, and I hope you felt it was advantageous. And for those in attendance, certainly thank you for joining us. And
Absolutely.
thank you, Stacey,
we'll get a recording. Oh, thank you, Robert. But we'll get a recording out to all of our attendees today. We'll also get those recordings somewhere down the line here up on our website. So ScaleHealth and MedHealth websites. We'll make sure everybody has links to that. And we'll follow up with our audience, make sure they have any resources they need. And thank you again to our panelists. And I do want to do a little shout out to Rebecca Derderian and Michelle D. Marchio. I know I'm pronouncing her last name wrong, but they have been the Tech Town techies, if you will, on the backside of all this. So there's Rebecca. So just want to say a big thank you to them for coming in and helping us on the backside. And thank you to all of you. The work that you're doing is tremendous. And we're really, really pleased that you're out there working for the benefit of all of our frontline workers and beyond. So thank you.